Okay, I'm going to discuss a case presented to me in Morning Report yesterday. And there's one take home point I want to make out of this complicated case, but it's an important point. Before that, it should be known the way Morning Report used to be when I was a resident in the early mid 80s. You would present a case or cases that came in the night before. There were not elaborate presentations. You just presented what came in. And morning reports at that time could be harsh. Now they're more elaborate case presentations with slides and summaries and sometimes journal references. Different now. 84-year-old man. He had multiple comorbidities. I do not have his chart in front of me. He had hypertension. I think he was diabetic, chronic kidney disease, mild aortic stenosis. And there's no history of substance abuse. He came in obtunded. Family brought him in. I don't know how long he's obtunded, but he was obtunded. His temperature, I believe, was 101.7. His heart rate was increased, I don't know how much, and his BP was somewhat soft at 101/60. He was not hypoxic, and his exam was really unremarkable, except neurologically. He was obtunded. Couldn't answer any questions. Blood work on him, his white count, I believe, was 13 to 14,000, and he had a little bit of lymphocytosis. Hemoglobin was not that low. Platelets were okay. His creatinine was 2, and I think he normally runs 1.6 to 1.8. I don't have his labs in front of me, and his lactate was slightly elevated. Okay, so what does all this spell sepsis? Okay, you don't need to be Sir William Osler to realize that this guy's probably septic. So of course they get a CAT scan of his head, which is unremarkable. They get blood cultures on him. His chest x-ray did not reveal anything, and his urine was not abnormal. So they CT his body, chest, abdomen, and pelvis. And he had, I believe, he had lymphadenopathy in his chest and abdomen. I think actually, I'm pretty sure he had it in the supraclavicular and maybe hilar nodes. No, supraclavicular and axillary nodes. And the abdomen was actually a question mark. He didn't have nodes in his abdomen on second blood. He had a thickened bowel. Abdomen was totally soft on exam. So the issue is what to do. And this is really a timeless question. So number one, he got IV fluids, and I think he got lactated ringers. 30 milliliters per kilogram. He got the typical sepsis dose. And they started on broad spectrum antibiotics. And he got Vanco and Zosyn, which is broad spectrum, and I agree with that. But what's missing here? What is missing? This guy's really obtunded. He hasn't woken up, and there's no clear-cut source of infection. What is missing is an OP. And this has been topic of God knows how many morning reports. Did you or did you not get an OP, and why not? This guy came in septic, fully obtunded, change of mental status, and no source of infection. And the patient was evaluated. He was in the ER. When he was admitted, luckily, he went up to IR, and they did an LP. Now, normally, back in the day, we did LPs on the floor or in the ER. They didn't go to IR. And I don't have his LP results as far as the cell count with there for the chemistries, although I can imagine what they were. But he had Cryptococcus and herpes simplex 1 growing out of his CSF. So he got liposomal amphotericin B, flucytosine, and IV acyclovir. So they did the right things, and it was a little bit of a time delay, but there really wasn't that much. Unfortunately, it was not a great outcome. But the issue is doing an LP. And when somebody comes in and they're septic, and especially with an extreme change in mental status. Now, encephalitis causes more of a change in mental status than meningitis. Meningitis usually causes severe headache, photophobia, some abnormalities on physical exam, neutral rigidity, Koenigsegg-Brzezinski sign. But he also had encephalitis. So I don't know why he had both of these. He was HIV negative. And it looks like he probably has CLL, and CLL could cause impaired humoral immunity, and you could be prone to infections with encapsulated organisms. So patients with CLL usually do not get cryptococcal meningitis, and he probably got it through the lungs and it disseminated throughout his body. We had no travel history at all. The major point is that if somebody's coming in septic and you don't know what the source is, do an LP early. Okay, do an LP early. Whether or not you need a CAT scan before this is really debatable. Usually they get their brain image before that, even if their exam is non-focal. The issue is, when in doubt, do an LP. That's it.